All right, so it gets more interesting now. So now we add another level of complexity is the unilateral mandibular elongation, long face syndrome, no cheeks. Look how flat that is. One cheek smaller than the other. Facial asymmetry. So this whole face is twisted this way. So the chin is approximately 2 centimeters off the midline, approximately. This eye is lower about 2 millimeters down. So I really take time and examine them, especially like before the surgery, before we're going to cut. I really spend time and examine them facially. So that's his pre-orthodontic treatment right there, situation right there. He has class 3 malocclusion, unilateral mandibular hypoplasia. So it's asymmetric case. So what do I do with them? He gets braces and he gets the best alignment he can. Orthodontist actually does a beautiful job, and they make him one-piece Lefort, which is nice for those big cases. If you don't have to expand the upper jaw, it's a little bit more stable, especially if you're doing big movements. But he's missing tooth here. You know, there's absolutely no bone. He'll need a blow graft later, or bridge. He's probably not going to go for a bridge because he doesn't want to cut those teeth. There's a baby tooth there. So we're leaving a lot of things as they are for now. But look what we've done. We do reverse treatment planning. What does it mean? I ask him to move his jaw to the right side because he has deformity to the left. So move it to the right, walks by. So his midlines are not fine now, right there, but he still has occlusal cant. But we minimize the deformity because I don't care what those condyles are right now. I want to see how bad is the lateral deformity, like his Orthognathic. And it's still bad, but it's actually not too bad. So that's what we do. You see, I put him in the splint and ask him to move his jaw to the left. So now all of a sudden he's more or less symmetric. So I know it's going to be an easy case to do. If he won't be symmetric, like I know there's some residual asymmetry. I have to cut the inferior border here. I have to reposition the chin. I have to take this angle off to make his mandible symmetric, which we'll see in a little bit. But it's not a very difficult case. So it's not a combination where orthodontist has to totally change occlusion for us to do the surgery, because sometimes we have cases when orthodontics is so compensated. We have to do a lot of things to decompensate to do the surgery, and we have cases like this. But this is his lateral ceph. This is his 3D, so we can appreciate the deformity right there. Again, the ceph. His team J's are okay, they're not big. But look at this, his mandible is actually fine. And I don't disagree with that, just off, but it's not that bad, 78. So here Steiner is actually not too bad right there. And but SNA is off a little bit, which I agree to. So for this guy, that's what we send to insurance companies. They want the sella, nasia, and all those angles here. And in this patient, it's just like playing a roulette. Okay, this one worked. And he didn't get approved because he's normal. Until we sent him a picture like this. Okay, because on the ceph, you can't plan this case on the ceph. You have to plan it in the frontal plane. So this is different planning. It's the planning in the frontal plane, not in the cephalometric. So it's 3D. It's like this. So how do you put his head? Where do you start to plan him from? Well, you just select the plane with the lasers, and then you do it from there. You just have to find arbitrary plane where you set up the face. That's your position, and then you go from there. You just have to assign it in your head as a clinician, and go from there. So this is his face several weeks after surgery. This guy And the other guy that I showed you with the big jaw, they didn't take a single pain medication after surgery, not a single pain pill. The guy that I showed you before with the big jaw advancement, the handsome guy, he was on pain medication for like 3 months, Percocets, day and night. He was in a lot of pain for some reason. I guess those big stretches will make the difference. This guy, not a single pain killer.
How old is he?
The other guy was 28 or 29. This one is 23. Sarah college student. So he's still swollen. You can say, well, doctor, his left side is still asymmetric. It's swollen. We took a lot of bone from there because so I took out this whole periosteum and we cut the extra bone away. His bite now. And again, belts and suspenders. It's for me it was easy in a sense because it was one piece Lefort, so just one piece movement. So that's him again. And that's him about 3 months, 4 months after. We did him in August, I think. So I think August or July. So what did we do? We brought his upper jaw forward and midline, and it was differential impaction because he was canted like this. And this is mandible first too. So all those you're supposed to do maxilla first in those cases. Some doctors recommend, but we did mandible first. And he got cheek implants too because he needed them. He was very, and he's very short. He's a dwarf, so he's. You won't see him if you stand here. So in those cases, when the body is small and the head is 30% of the body mass, we worry about bleeding. Again, we're glad he didn't bleed a lot. So we prepared 2 units for blood for the surgery, but we didn't need it. So again, his bite before and after. His airway didn't change much. You can see his skeletal change. So again, reverse treatment planning. So what do? We do initial in the centric relation, so to speak. Those patients, it's hard to find centric relation. They don't know where it is. Then we do reverse, and that's final. Soft tissue changes are great. This is overlay of 3D before and after, so you can see all this was trimmed right there. So the blue is the new position, so it's symmetric. This is old. So that's the guy right there. So this vertical change makes a big difference.